Hi guys, it's me, Professor D, and welcome back to my channel. On this video, I'm going to be covering part 2 of my 3-part series on fluid and electrolytes. If you haven't watched part 1 already, please be sure to do so. Part 3 is coming soon, and in part 3, I'm going to be using visual aids. So for my visual learners, make sure you guys watch out for that. So you guys know what comes up next. If you haven't done so already, be sure to like and subscribe below. Press that red bell so you'll be notified every single time a new video is released. And of course, guys, if you appreciate the content that I'm bringing to these videos, please be sure to share my videos with anyone you know, any nursing students or recent grads, anyone you know that these videos will help them. Please be sure to share. So without any further ado, guys, let's get started. First question. The home health nurse knows that an elderly patient has a low serum protein level. The nurse will plan to assess for A, pallor, B, edema, C, confusion, or D, restlessness. Now I'll give you a moment to think of your answers. If you're new to my channel, just press the pause button. Whenever you're ready to continue, press play. So the correct answer, guys, my camera's moving, sorry. The correct answer, guys, is B, edema. So let's talk about this. Albumin is a type of protein and it's in the blood, right? That portion of the blood, albumin, which is a protein, that is what keeps the blood and the fluid inside of the vessels. Okay? So as soon as a patient's albumin level goes down, whether, they have a kidney problem and they're getting rid of their albumin, remember, it's a type of protein, and protein keeps the fluid in the vessels. So for whatever reason, if the patient's albumin level goes down, guess what? All of that blood, all of the fluid that was in the vessel, they're now free. And guess what they do? They get the heck out of there. They shift. And so they leave the vessel and they seep into the tissues. So what you see when the patient's protein albumin level is down, you see the patient has edema, such as pitting edema. You might see periorbital edema. You might see anasarca. Why? All of the fluid, all of the blood that was in the vessel, the protein was keeping it in the vessel, but now that the protein's gone and all that fluid is free, it leaves the vessel and it goes out into the interstitial tissue. So what we expect to see whenever the patient's protein, the serum protein level is down, we expect all of that fluid to seep out of the vessels and go into the tissue. So we expect to see edema. So the correct answer is B. Next question. Patients receiving 3% sodium chloride solution for correction of hyponatremia. During administration of the solution, the most important assessment for the nurse to monitor is A, lung sounds, B, urinary output, C, peripheral pulse, or D, peripheral edema. And I'll give you a second to think of your answer. And so the correct answer, guys, is A, lung sounds. Why? I want you to think about this. Patients receiving sodium chloride to correct hyponatremia. Okay? So 2 things going on. Hyponatremia, many times when the patient has hyponatremia, what happens is there's too much fluid going on and it dilutes the sodium, and that's why you see the sodium low. So possible what? Fluid overload. And 2, that patient's getting 3% of fluids, which is a sodium they're replacing. So what are we concerned when the patient's getting fluids? We're concerned about them possibly getting too much fluid, that patient going to fluid overload. What happens when that patient has too much fluid? Too much fluid in the vessels. Well, guess what? It's got to go somewhere, right? They spill over into the lungs. So you want to listen to the lung sounds and make sure that patients doesn't have crackles, which is a sign and symptom of what? Fluid overload. Are you supposed to hear crackles? Is there supposed to be signs and symptoms of fluid in the lungs? No. So the most important thing that we're going to worry about is lung sounds. We want to make sure that the fluid has not gone into the lungs. So the urinary output, the peripheral pulses, peripheral edema, yes, all of those are important. All of those we want to look out for, but the most important is airway. We want to make sure that that patient has not gotten fluids in the lungs. So that's why A is a priority. The long-term nurse is evaluating the effectiveness of protein supplements on a patient who has a low serum total protein level. Which of these data indicate that the patient's condition has improved? A, hematocrit of 28%, B, good skin turgor, C, absence of peripheral edema, or D, blood pressure 110/72. Okay, guys, and the correct answer is A, the absence of peripheral edema. We know that that protein is getting better when we see a shift of fluid going back from the interstitial and back into the blood where it belongs. Because remember what I told you happens. When the serum protein is low, the fluid's free to go everywhere, so they leave the vessels and they go out into the tissues. But as the patient starts to recover and the serum protein increases, all of that fluid is pulled, it's shifted back into the vessel where it belongs. So the way that we know that the protein is getting better is when we see C, absence of peripheral edema. Why is there no more peripheral edema? All of that fluid that was in the tissues has gone back into the vessels. A patient has the following arterial blood gas results. The pH is 7.32, the PaO2 is 88, the CO2 is 37, and the bicarb is 16. The nurse interprets these results as A, metabolic acidosis, B, metabolic alkalosis, C, respiratory acidosis, or D, respiratory alkalosis. And I'll give you a moment to think of your answer. And the correct answer, guys, is metabolic acidosis. How did we figure that out? Well, as I said in the first video, the first thing you always want to do is look at your pH. Your pH is the key to let you know if the patient's in acidosis or alkalosis. So when we look at the pH is supposed to be 7.35 to 7.45. Anything less than 7.35 is acidosis. And anything more than 7.45 is alkalosis. So when we look at this pH and we see it's 7.32, that lets us know the patient is in acidosis, because anything less than 7.35 is acidosis. So we've established the patient's in acidosis, but now we need to figure out, is it metabolic or is it respiratory? And this is where you look at your other numbers. You look at your CO2 and you look at your bicarb to see which one is out of whack. If the CO2 is out of whack, we're dealing with respiratory. If the bicarb, your HCO3 is out of whack, we're dealing with metabolic. So let's take a look. Our CO2 is 37. Your normal range is 35 to 45. Less than 35, you're more acidic. More than 45, you're more basic, more alkalinic. It's 37, so it's within range. So we know we're not dealing with respiratory. Let's look at our bicarb. When we go to the HCO3, HCO3 should be 22 to 26 or 27, depending on the book that you're using. But whoa, our bicarb is way out of range. It's 16. So we know we're dealing with metabolic acidosis. We know it's acidosis again because we looked at the pH. And so the correct answer is A. Next question. A patient who's been receiving diuretic therapy is admitted to the ER with a serum potassium of 3.1. Which of the following medications that the patient has been taking at home the nurse will be most concerned about? A, oral digoxin 0.25 milligrams daily. B, ibuprofen 400 milligrams every 6 hours. C, metoprolol 12.5 milligrams orally daily. Or D, Lantus insulin 24 units sub-Q every evening. And the correct answer is A, oral digoxin 25 milligrams daily. Why? If you guys watch my video on pharmacology, I told you that this is one of the most important things you need to know about meds. You're definitely going to see it on tests when it comes for pharmacology. You have to know this. When a patient's taking digoxin, you absolutely must pay attention to the potassium level. Why? Because a low potassium will cause the patient to have dig toxicity. What can dig toxicity cause? Cardiac dysrhythmias, right? So whenever a patient's taking digoxin, you're going to look at the potassium, and the potassium is supposed to be 3.5 to 5. Anything less than 3.5, which is hypocalcemia and those signs and symptoms that come along with it, you're going to see dig toxicity. What are the signs and symptoms of dig toxicity? You may see blurred vision, nausea and vomiting, right? So that's very important when a patient's on digoxin. Let me tell you a couple things you're going to be checking. You're going to be checking the apical pulse for 1 full minute, right? And if their heart rate is less than 60, are you going to give the digoxin? Absolutely not. You're going to hold it and call the physician. Why? We love digoxin. It's a great med. We use it a lot for CHF because it increases the contractility of the heart. But another thing that digoxin does is decrease the heart rate, right? And we don't want that heart rate being decreased to lower than 60. So we're going to take an apical pulse for 1 full minute. And if the pulse is less than 60, we're going to hold and call the doctor. Another thing you're going to do is look at the potassium levels. 3.5 to 5. Anything less than 3.5, you're going to hold it and call the doctor because you do not want that patient to go into dig toxicity. And that brings me to my third point. You're going to be looking at the dig levels. You're going to be watching out for signs and symptoms of dig toxicity. Next question. A patient with hypercalcemia is being cared for on the medical unit. Nursing actions included in the care plan will include 1, maintaining the patient on bed rest. 2, auscultating lung sounds every 4 hours. 3, monitoring for Trousseau's and Trost signs. Or D, encouraging fluid intake up to 4,000 milliliters every day. And the correct answer, guys, is D, encouraging fluid intake up to 4,000 mLs every day. Why? What are we dealing with? Hypercalcemia. And what can happen when that when the calcium's too much in the blood, right? So it's flowing in the blood, it's flowing, but we got way too much calcium in the blood. Want to know what happens when it gets to the kidneys? It clumps up and patients got kidney stones. Well, if you watch my priority and delegations video, I was very clear. Okay? Pain never killed anybody except in 3 situations actually 4, that we treat pain as physiological integrity. What is it? Myocardial infarction, burn, sickle cell, and stones, such as kidney stones caused by what? Calcium. All right? So that is a priority for us. We do not want that patient with hypercalcemia to go through dehydration, because if it starts to be dehydrated, the calcium starts to clump up, then it gets to the kidneys. Patients got kidney stones, and that pain from the kidney stones, blocking and obstructing blood flow, that can cause the patient to go through shock. And potentially kill the patient. So whenever a patient has hypercalcemia, you want to make sure that you're killing them with fluid. You're giving them lots and lots of fluids. You want that calcium to be diluted so they don't have a chance to clump up and become kidney stones. Okay? Now let's look at our wrong answer choices. We have 1, maintain the patient on bed rest. Wrong. You want to help push that calcium out of the blood and back into the bone. How do we do that? Weight-bearing exercises. You want the patient walking around, right? Because them walking around or doing weight-bearing exercises will push that calcium that we have too much of. It'll push that calcium out of the blood and back into the bones to make the bone stronger, right? It makes the calcium less in the blood. So 1 is wrong. You don't want them on bed rest. Those patients that have osteoporosis, or they have conditions where the bone calcium is low, or they have a condition where that calcium in the blood is too high, we want them walking around. Them walking will pull the calcium out of the blood and go back into the bones, all right? Or it can pull it out of the blood and have the patient urine out, depending on the condition that's going on with them. So A's wrong. Choice B, auscultate lung sounds every 4 hours. We always want to auscultate lung sounds. That's wonderful. But that's not our priority for the patient with hypercalcemia. Our priority for the patient with hypercalcemia is giving them fluids to prevent dehydration. When we prevent dehydration, we prevent it from clumping up. When we prevent it from clumping up, we prevent it from going where? To the kidneys and causing stones, which can cause what? Shock. Okay? Choice C, monitoring for Trousseau's and Chostek sign. Well, we do this for hypocalcemia, not hypercalcemia. All right? When a patient goes through hypocalcemia, that's when they have those signs of muscle nerve irritation. They may have tetany, not hyper. Okay, so that's wrong. And that leads us to our correct answer, which is choice D, giving them lots of fluids. When teaching a patient with renal failure about a low-phosphate diet, the nurse will include information to restrict A, ingestion of dairy products, B, the amount of high-fat foods, D, the quantity of fruits and juices, or D, intake of green leafy veggies. And I'll give you a moment to think of your answer. And the correct answer is A, ingestion of dairy products. Why? The question just said the patient is on a low phosphate diet. And if the patient has kidney damage, they are going to be on a low phosphate diet. Well, guess what? Dairy products, milk, cheese, they are high in phosphate. So we have to restrict that from the patient's diet. Next question. The nurse in the outpatient clinic who notes that a patient has a decreased magnesium level should ask the patient about A, daily alcohol intake, B, intake of dietary protein, C, multivitamin mineral use, or D, over-the-counter laxatives. And I'll give you a moment to think of your answer. Ooh, I'm out of coffee. Okay, guys, so the correct answer is A, daily alcohol intake. So alcohol is strongly associated with hypomagnesemia, right? Not having enough magnesium in the blood. So those patients that are alcoholics, you tend to see them have low magnesium levels. So that's what you're going to be asking the patient about. That's what you're going to be looking out for. Now let's talk about our wrong answer choices. You have B, intake of dietary protein. Dietary protein has no effect on magnesium the way alcohol does. Alcohol decreases magnesium levels. Dietary protein does not. Choice C, use of minerals or multivitamins. Those actually increase the magnesium, not decrease the magnesium. So that can't be our answer. And then you have choice D, over-the-counter laxatives. That also increases the magnesium level, not decrease. So the only correct answer here is alcohol, which actually decreases the magnesium level. A post-op patient who's receiving NG suctions complaining of anxiety and incisional pain. The patient's respiratory rate's 32 breaths per minute and the arterial blood gas indicates respiratory alkalosis. Which action should the nurse take Which action should the nurse take first? A, discontinue the NG suction for a few hours. B, notify the health care provider about the ABG results. C, notify the patient about the need to take slow, deep breaths. Or D, give the patient the PRN morphine sulfate 4 milligrams IV. And I'll give you a moment to think of your answer. And your correct answer, guys, is D, give the patient the as-needed morphine sulfate 4 milligrams IV. Why? I want you to think about what's happening here. Patient's going through respiratory alkalosis, right? Remember, in my first video I did on fluid electrolytes, I talked to, in acid-base balance, I talked to you guys about this. I told you when the kidneys are in trouble, the lungs are the only guys that can help. And when the lungs are in trouble, the kidneys are the only guys that can help. So if the patient's in respiratory alkalosis, they're going through alkalosis, so that means they've got too much bicarb, right? So we're looking through our list to see what we can do to make the patient go from an alkalosis to an acidic state. Well, guys, who's responsible for acid? The lungs. The lungs can only do two things, either increase respiratory rate or decrease respiratory rate. If the lung increases respiratory rate, they're blowing off all their carbon dioxide or carbon diacid, as I say, right? Which will make a patient more alkalosis. Well, the patient's already in alkalosis state. So we don't want their breathing to increase. We don't want them to blow off more CO2. We're trying to hold on to CO2 because the patient's alkalotic, and which is alkalotic a word? I'm not sure. They're going through alkalosis, and we're trying to bring them back to a more acidic state. So what do we want them to do? Slow down their breathing so they hold on to the CO2 because CO2 is acidic. Well, what can we do to slow down the breathing to hold on to the CO2? D, what do opioids do? Slow everything down. Yes, the opioids decrease pain, but it slows down the blood pressure, brings the blood pressure down, slows down the heart rate, slows down respirations. When the respirations slow down, the patient's holding on to more of their CO2, and it throws them into a more acidotic state. Okay, so that is why D is your correct answer. Now let's look at our other choices. We have A, discontinue the NG suction for a few hours. That's not appropriate to do. That's been ordered. The patient needs that NG suction. B, notify the doctor about the ABG results. Remember, I told you guys, before you ever choose the answer of call the doctor, say to yourself, is there anything I can do for my patient first before I turn my back to call the doctor? And there is something you can do in this situation. So we're not going to call the doctor yet. We're going to look at choice C, teach a patient about the need to take slow, deep breaths. Well, guess what? They're not going to do this if they're in pain. We just saw in the question that the patient was complaining of incisional pain. So we're going to do D. We're going to kill two birds with one stone. One, we're helping them with the pain by giving them the morphine, which has been ordered. And two, we're slowing down the breathing, which will help with the alkalotic state. So we're killing two birds with one stone by choosing the answer D. Which assessment finding about a patient who has a serum calcium level of 7 is most important for the nurse to report to the doctor? A, the patient is experiencing a laryngeal stridor. B, the patient complains of generalized fatigue. C, the patient's bowels have not moved for 4 days. Or D, the patient has numbness and tingling around the lips. And I'll give you a moment to think of your answer. Okay, guys, your correct answer is A, the patient's experiencing a laryngeal stridor. So, guys, the first thing you guys need to know, the calcium level should be 8.5 to 10.2, maybe 10.3, depending on the book that you're using. But that's generally the area, 8.5 to 10.2. That is your calcium range. This person's calcium is 7. What does that mean? The patient's going through hypocalcemia. Now, what did I tell you signs and symptom of hypocalcemia? Muscle and nerve irritation, excitability, right? We see tetany, okay? So, choice 1, 2, 3, 4. All of those, yes, we see with hypocalcemia. Absolutely. But what's the priority out of all of these? And it's 1, stridor. You hear stridor, that is a medical emergency. That patient's going to stop breathing very soon. Stridor is the sound that you hear when that patient's airway is closing up on them. So you hear stridor, you better have an airway kit available immediately because that patient's going to stop breathing very soon. So that by far is going to be our priority out of all the choices that have been presented to us. Next question. Following a thyroidectomy, a patient complains of a tingling feeling around the mouth. The nurse will immediately check for A, elevated potassium level, B, presence of Chostek sign, C, decreased thyroid hormone, or D, bleeding around the patient's dressing. And I'll give you a moment to think of your answer. And the correct answer, guys, is B, the presence of a Chostek sign. In the question, they tell us the patient just had a thyroidectomy. Well, what sits right down your thyroid glands? Your parathyroids. What are your parathyroids responsible for? Calcium. So when that patient was getting that thyroid removed, those parathyroids absolutely could have been nicked, and now the patient's going through hypocalcemia. What are signs and symptoms of hypocalcemia? Tetany, muscle nerve irritation, excitability. Chostek sign, Trousseau sign. Remember Chostek sign that starts with a C? That's the one where you touch your cheek and then she goes like this, right? That's what's muscle irritability that you see that happening. That's your Chostek sign, a sign and symptom of hypocalcemia. What is your Trousseau sign? Trousseau starts with a T. So does tetany. When you take the patient's blood pressure and you see their hands start to twitch, right? That's the Trousseau sign. So those are signs and symptoms of hypocalcemia. And we saw a hint. They told us that the patient had a thyroidectomy. Whenever you hear a thyroidectomy, you better be thinking that maybe those parathyroid glands got affected and the patient is possibly going through hypocalcemia. And if you guys didn't get that, they gave us another hint in the question. Tingling around the mouth. That tingling that the patient's feeling is that muscle nerve irritation, which is a sign and symptom of hypocalcemia. All right, guys, we're down to our last question. A patient with advanced lung cancer is admitted to the ER with urinary retention caused by a renal calculi. Which of these lab values would require the most immediate attention by the nurse? A, arterial blood, pH 7.32. B, serum calcium of 18. C, serum potassium of 5.1. Or D, arterial oxygen of 91%. Now I'll give you a moment to think of your answer. And the correct answer, guys, is B, a serum calcium of 18. Remember, I told you that your normal calcium is 8.5 to 10.2. 18? I want you guys to think about it. If hypocalcemia, when the calcium is too low, if that causes muscle and nerve excitability and irritability, what do you think happens to the muscle of nerves when the calcium's too high? The opposite, muscle and nerve relaxation or paralysis. Isn't your heart a muscle? So guess what? That can cause your heart to stop and the patient will die. So a priority out of this is going to be that calcium, because that patient's heart can stop, and very well may with a with a calcium of 18. Let's look at our other choices. You have A, arterial blood, pH 7.32. Well, your normal range is 7.35 to 7.45, right? If it's 7.32, the patient's slightly acidic. But when they're slightly acidic, what can happen? The lungs might try to compensate by holding on, by breathing faster to get rid of the CO2, right? And the kidneys might try to compensate by what? Holding on to more bicarb, making more bicarb and holding on to more bicarb. The 7.32, that's not a medical emergency like that calcium of 18. Choice 3, potassium 5.1. Yes, the potassium's out of range, but the range is 3.5 to 5. It's 5.1. Right? So that's not going to be as a medical emergency as that calcium that's 18. And then, of course, you have your O2 sat 91. We don't want the O2 sat to be 91. We want the patient to be between 95 and 100. 91, that does need to be addressed, but it's not like they're in acute respiratory failure as if the patient was in 88, right? 91, so it still needs to be addressed, but it's not a medical emergency like that calcium of 18 where that patient's heart is about to stop at any moment. So guys, those are the questions for part 2 of my 3-part series on fluid electrolytes. So guys, I hope you appreciated this video. Please watch out for part 3 where I will be using a visual aid so it can kind of just cement everything that I've been talking to you about, and I just want to make sure that it makes sense to you. All right, if you haven't done so already, please be sure to like and subscribe below. Press that red button so you'll be notified every time a new video is released. And as always, guys, if you want to encourage me, and thank you, by the way, I'm seeing the comments and it warms my heart when you guys are putting comments and letting me know how much I'm helping you. It really is a drive and encouragement for me to just keep pushing these videos for you, because I want you to succeed. I want you to be able to put your best foot forward and have this information. So when you sit down for your test, you kill those tests. That's what makes me happy. So thank you so much for the comments. Please, and if you guys want to encourage me even more, share my videos. Share my videos on your Facebook, on your Instagram. And guys, I'm old, so I don't even know what else is out there. But whatever else is out there that people are watching, please share my videos so they can come, watch, and subscribe. Thank you for spending this time with me, and I'll see you next time.